vault. So to me, it would be nice to like be able to ask her the cage questions just to be able to further assess if how in control she is with her alcohol drinking.
Good. So, I mean, you actually brought up several points here that it's worth reviewing. The DSM diagnosis of alcohol use disorder, formerly broken down into two types, alcohol dependence and alcohol abuse. In 2013, with the publication of the DSM-5, the American Psychiatric Association merged the two definitions and came up with a single diagnosis now called alcohol use disorder, for which the individual only needs to meet two criteria. So it's a relatively low threshold. Of course, in meeting those two criteria, there must be some clinically significant impact on their daily functioning. And what you reviewed actually checked the boxes for several of the criteria. So number one, you identified a loss of control. So that is definitely a DSM criteria, loss of control with regard to the use of the substance. And we see that here with Elaine. Interpersonal conflict as a result of substance use. We see that as well with the idea of her not being able to keep things in the vault. So that's a second criteria. And then we see some physical consequences too, chipping her tooth. So that is another criteria that you can check as well. All of these, of course, must be clinically significant, and we see that as an outcome with regard to the subplot of this particular episode, the betrayal. So this is concerning. The other thing for those of you who are Seinfeld fans, you may recall in a previous episode that Elaine actually refers to her father as an alcoholic. He's not in too many episodes, I think maybe 2 or 3, but in one of the episodes where she makes a reference to her father, it's a single line, and certainly we may be taking this out of context, but she does provide a history, specifically a family history. If we look at this and frame this with regard to a history and physical examination, that is a psychiatric evaluation, a family history of alcohol use disorder, and we do know that there is a genetic component to this. I think what's further interesting is that we would expect alcohol use disorder in any character to be stable over time unless there's intervention. And it's interesting that we don't see that. And again, please correct me if I'm wrong. I don't know of other episodes where the focus is on Elaine, and more specifically, the focus is on Elaine with regard to her drinking behavior. And then the final thing I'll say, another point that you had brought up, is that you mentioned the clinical impact or consequences, right? The functional impairment that I think this particular episode demonstrates, and it's true. And that's one thing that we have to make sure that we communicate to our learners and even our peers in other departments and other subspecialties, because along with our patients, many believe that there is some type of quantifiable definition with regard to substance use, and that applies to alcohol, cocaine, cannabis. If the individual is being functionally impaired, it does not matter how much you use, right? So many people, when you begin discussing the impact it has on their interpersonal relationships, may actually respond in saying, I don't drink every day, or I don't even drink every weekend. And one of the things that I think clinicians must communicate to patients and their families is that that doesn't matter. If there is some consequences, or if there are identified consequences to the drinking behavior or the drug use, then we are likely meeting the definition of a substance use disorder. And in Elaine's case, for this episode, it is likely alcohol use disorder. So Elaine presents to you after what happens at this wedding and says, I have to talk to you about something that happened with an ex-boyfriend of mine. He was getting married. There were some problems when we went to the wedding, and it's causing me distress. And doc, I think I may have anxiety. And she begins to talk to you about this. And what you then uncover in the patient's report is the actual plot of the betrayal. You might identify here that whether it's an etiology of her anxiety or co-occurring with, Elaine has an alcohol use disorder. From a clinical perspective, what might you discuss with this character with regard to treatment planning? What are you going to offer her?
I guess I would want to find out just to quantify how much she is drinking to see if there's also a component of physical dependence and see if we would have to, as well, for the short term, get her on some benzodiazepines just to avoid any of the acute withdrawal symptoms. And then more long term, probably something that would help with the cravings, naltrexone or a camproside or disulfiram. So
Good. All right, so let's talk about this. So you're employing a biopsychosocial perspective, and your primary focus, your initial focus anyway, is going to be on the biological aspect, that is those biological factors that are part of the comprehensive biopsychosocial treatment plan. One of those would be the individual's risk for undergoing withdrawal. And there is a significant physiologic withdrawal state associated with alcohol, and it is potentially life-threatening. So it is a very good idea for the clinician to focus on this first. You mentioned a couple of things. What information might you want from Elaine here to really gauge her level of risk? 3 things to consider.
I was thinking along the lines of doing the CAGE score to really understand her, how much like she's drinking and how she feels about it. So CAGE, I forgot what C is, but A.
Cut down.
Sorry?
Cut down.
Yes. Do you ever feel like you need to cut down? A, do you ever feel like others are annoyed by your actions? G, do you ever feel guilty? Or do you feel guilty for the way you acted when you were intoxicated? And then E, do you need an eye opener in the morning? So that could be a quick, easy way to gauge where she's at.
So this is a screening tool. And while in research, it is arbitrarily agreed upon that answering 2 of those questions results in a positive screen. In clinical practice, answering 1 question is considered to be a positive screen with a sensitivity in the mid-90s, right? So 1 out of those 4 answered yes by a person, by a patient, rules in as a positive screen. You did mention then how much, get an idea of how much she's drinking, and that would be the next step, how much and how often. And it is the answer to these questions that are going to inform the clinician about the risk assessment, all right? That is the level of risk. If Elaine is drinking, let's say the equivalent of 6 drinks per episode, once every 6 months, that's not likely something that the clinician would be concerned about pertaining to a prospective withdrawal state. Of course, if she's having 6 drinks per day and has established that pattern over the past 6 to 8 months, that's much different. And I will get you, and I'll even post on Instagram, the actual cutoffs with regard to both male and female, how many per episode, and then how many episodes per week would indicate a positive screen in that secondary assessment. That is the assessment of how much and how frequently following a positive CAGE screen, right? So we'll post that later. The other thing that the clinician may consider is to simply cheat, and that is to review the signs and symptoms of alcohol withdrawal and simply ask Elaine, have any of these ever occurred when you've tried to cut down or when you've stopped drinking? And if she says yes, you know what, her level of risk is likely high, and it will certainly inform the clinician's next step, which might be, as you had mentioned, placing her on a benzodiazepine to mitigate or medically manage the physiologic symptoms of alcohol withdrawal. Once she's through a withdrawal state, I heard we had feedback that there are 3 medications that are FDA approved for the treatment of alcohol use disorder during the recovery phase. So as the individual is recovering, the biological or somatic agents that are part of the biopsychosocial treatment plan do include 2 that reduce craving, that is naltrexone and a camprosate. And there is 1 that works through a different mechanism called disulfiram. So as not to overly focus on one character and one illness, today during rounds, we'll discuss disulfiram, and more specifically, the disulfiram reaction and its role in a recovering alcoholic. All right, so that's Elaine. Any other aspects of Elaine anyone would care to identify, discuss? Any other character you thought is worthy of our analysis this morning?
I thought the character of Kramer, um, with the whole feeling like someone was out to get him, like he showed a lot of superstitious, paranoid behavior with trying to negate this person's wish that he drop dead, to the point where his relationships with like Newman and this guy were affected. There were several different superstitions that he had, like with the wishbone, wishing on a shooting star, pulling out eyelashes, all of that just to counter this person's like bad luck that he kind of gave to him.
Good. So let's talk about what behavior you identified and clinically labeled as a superstition. Sometimes in clinical practice, we substitute the term overvalued idea. And generally speaking, whether we call it a superstition, whether we call this an overvalued idea, it's considered to be a deficit in thought content. Thought content itself is one of the several domains that build or are part of the routine mental status exam, right? So the routine mental status exam has several domains, one of which is called thought content, and one potential deficit in thought content is called the overvalued idea, AKA the superstition. Before we talk about this, so again, I wanted to make sure I framed that correctly. Before we talk further about the overvalued idea, especially as it applies to this character Kramer in the Betrayal, can anybody give me other examples of deficit in the domain of thought content? Another example would be suicidal ideation. So all of a sudden, when a clinician probes thought content, they are automatically providing a safety assessment, whether the individual presented with a chief complaint of depression, anxiety, or a sore throat. The routine mental status exam is a routine part of the general physical exam. So whether the patient presents with a somatic complaint like a sore throat or a psychiatric or emotional complaint like depression, the MSC would be applied, and certainly thought content would be evaluated. Suicidal ideation. Another example would be homicidal ideation. Then we have superstitions, overvalued ideas. And there is another term we often hear and use called themes. So there are really three parts. If you want to actually build this as an outline, there are three parts of thought content: suicidal ideation, homicidal ideation, and themes. One example of a theme is called the overvalued idea. The overvalued idea is considered to be the mildest form of deficit within this domain. Anybody here want to give me an example of a more severe form? Another some more severe theme that may be uncovered upon the clinician's investigation or evaluation of thought content. The easiest example here is the delusion, right? The delusion. And the delusion arbitrarily is considered to be the most severe form. And then there's a whole bunch of clinical terms we use to connect those dots. In Kramer's case, I want to just bring up one of those clinical terms that appears to be more severe than the overvalued idea, but less severe than the delusion, right? And first, the group will actually provide me feedback. Do you think Kramer's behavior is clinically significant?
I would say, are we talking about his behavior in just this episode or his behavior as we've seen?
In this episode.
I would say potentially yes, but it's hard to not think about his prior behaviors, and I think that it could be yes, but it looks, since he has a consistent behavior of like being kind of neurotic, it's leaning more towards personality disorder than something acute.
Agree. All right. So if we are going to identify Kramer's behavior as clinically significant, we are probably not going to use the clinical term of the overvalued idea in describing Kramer's behavior arbitrarily, whether we call it a superstition or the overvalued idea. We believe that these are not clinically significant examples of deficit in thought content. Therefore, I think this episode allows us to actually choose another term, introduce another term that, while less severe than a delusion, certainly would be more severe than the superstition, in as much as it is deemed to be clinically significant. And here, there are two terms that pop up. One is a preoccupation. Do we think Kramer becomes preoccupied with regard to what he has to do to undo the curse that was put on him? And then the other clinical term is the obsession. Do we think Kramer is obsessed with regard to undoing the bad luck? And if the answer is yes, and we think it's clinically significant, then basically we can toss a coin, because the terms obsession and preoccupation are relatively interchangeable. If we believe that Kramer's behavior is part of a larger disorder called obsessive compulsive disorder, the clinician should use the word or term obsession. And if we don't think it's part of that larger disorder called OCD, then the clinician may use the alternative term of preoccupation. All right. So again, there's no real great rhyme or reason whether we're going to choose one of those clinical terms versus the other. One is not necessarily considered more severe than the other. And I think in clinical practice, unless we agree that it's part of a larger illness, those two clinical terms are usually interchangeable: a preoccupation and an obsession. So I think those are the major teaching points when it comes to identifying the behavior we see in this episode of Kramer. In addition to his obsessions / preoccupations, is there anything else that we have identified in this character that we'd like to discuss this morning? Any other characters you want to identify and talk about? By the way, just a quick tangent. Does anybody happen to know the two DSM diagnoses that actually use the word preoccupation in the definition? I mean, getting to my point of which term to choose, there's usually about 3 illnesses the clinician must consider as manifesting as through this deficit of thought content. If it's obsessive compulsive disorder, of course, we're going to call that deficit an obsession. Anybody know the 2 illnesses that, if manifest, the clinician then would identify that deficit in thought content as a preoccupation because it's consistent with the definition as published in the DSM? What are the 2 preoccupation syndromes identified by the American Psychiatric Association?
Like an eating disorder, maybe?
Good.
Maybe body
Exactly right.
disorder.
In eating disorders, the individual, and this is both for bulimia nervosa as well as anorexia, the individual has a preoccupation with body image. And there's one more.
I think the other one is the illness anxiety disorder.
Exactly right. That's great. Formerly known as hypochondriasis. Illness anxiety disorder is defined as a preoccupation with having or contracting a serious illness. Good. Illness anxiety disorder. Again, if somebody comes in and they are quote unquote obsessed with regard to getting a serious illness, COVID, and you think that that obsession is clinically significant, and meaning that it's impairing their functioning, You may not use that very word obsession. You may change the term to it's a preoccupation because you may want to be consistent with DSM vocabulary, right? Good. All right, so a couple minutes to go here. What are the characters interested you in this episode, The Betrayal? No, that's it. Elaine and Kramer. All right, so then we probably should backtrack just a little bit since we have a couple of minutes to talk about this and refocus on Elaine, and more specifically refocus on this medication called disulfiram. This medication is taken daily. Usually it started at 250 milligrams first thing in the morning and then bumped up to 500 milligrams after 3 to 7 days. And the individual is maintained on a daily dose of 500 milligrams taken first thing in the morning. If the individual then drinks while the disulfiram is at steady state, is in their system, they will become ill. They could become flush, they could have nausea, they could have certainly vomiting, they could even become hypotensive and faint. As a result of this, the next time they consider picking up a drink while being compliant with the daily dosing, they may think twice. So right there, the clinician must identify the type of patient this is likely to work best in, that is, have the best outcomes. And it would be someone who can learn from their mistakes. If the individual has a cognitive deficit, and that might be something covered formally with regard to cognitive testing, or perhaps even informally with regard to a mental status exam, and you don't believe that they can learn by consequences, then please don't prescribe this medication. This medication is an operant conditioning paradigm where individuals learn by their consequences. Operant conditioning, behavior that is reinforced will strengthen, behavior that is punished will weaken. So reinforcement versus punishment. What type of operant learning do you think takes place when an individual uses disulfiram?
It would be positive punishment.
So it's punishment, exactly right. Right. And you actually answer my next question as well. When you talk about punishment paradigms, by the way, when you talk about reinforcement paradigms, the same will apply. But in this case, when we talk about punishment paradigms in an operant conditioning scenario, the next thing to consider is whether it's positive punishment versus negative punishment. And your choice will be determined by whether something is added to the equation or subtracted from the equation. And in this case, you're adding disulfiram by prescription to the patient's treatment plan will result in you using the prefix, if you will, positive. So this is a positive punishment paradigm as part of operant conditioning, right? So that's how disulfiram works. It doesn't work by reducing cravings. So the answer is yes, you can actually co-prescribe this medication with acamprosate as well as naltrexone, because those two medications work by reducing craving for alcohol, while the disulfiram will work through a positive punishment paradigm. The actual mechanism of action of the other two medications are themselves different. Naltrexone is a mu opioid receptor antagonist, meaning that it will bind to the opioid receptor and it will prevent other molecules called agonists from binding to it. So as an antagonist, it will reduce craving, not only for alcohol, but for opiates as well, because it's the opiate receptor that it binds to. There is cross-reactivity with regard to the opiate receptor. So clinicians recognize that not only does it reduce the craving for opioids, but also for alcohol, and therefore it does have that secondary indication through the FDA for alcohol use disorder as well. Acamprosate's mechanism of action is a little less well understood, albeit different from blocking the mu opioid receptor. So you can actually co-prescribe all three medications if tolerated, right? Any other last minute questions with regard to anything we discussed this morning or the episode, the betrayal in particular?
Hi, Dr. Tobia. If you're prescribing disulfiram, is there a chance that you can induce some sort of panic disorder in the person when they're considering the negative side effects, and if they come in contact with anything they think might be alcoholic or something?
It's an interesting question. So the question of whether or not you can develop or initiate a panic disorder in an individual. Now, theoretically, the answer is yes. But what's interesting is that that's actually part of the paradigm, meaning when we think of anxiety and the severity across the spectrum of anxiety, there is something called avoidance behavior. That is, let's say an individual with an anxiety disorder, such as panic disorder, may begin to avoid going out so as to not become embarrassed in the event of becoming symptomatic and having a symptomatic panic attack. Of course, that if that itself becomes clinically significant, we call that agoraphobia, right? So avoidance behavior is part of anxiety behavior. And that's exactly what we're taking advantage of with regard to disulfiram. We're taking advantage of the avoidance behavior. Individuals will avoid drinking for fear of having that disulfiram reaction. To your question, even though that's the goal, can we overshoot it, so to speak, and actually create a panic disorder as a result? The answer, I guess, is hypothetically yes, although in the literature, I have not seen that. That is not established at all in the literature that I know of. But I mean, hypothetically, I guess you can. I could see the textbook drawing that up. I just have not seen it in the evidence-based literature.
Thank you.
And certainly, I think the risk of developing panic is far outweighed by the benefit of taking the medication. So even if it does or can occur, that should be part of the informed consent process, and your patient should understand the risks and benefits of taking disulfiram as they take any medication. And I certainly think the informed clinician should be able to discuss that the benefits of taking, including abstinence, and therefore full recovery, outweigh those risks. All right, we're right at the bottom of the hour. We're going to stop here. All right, I'll see the medical students in about a half hour, and everybody back at 12:30 for our film discussion today. Have a good morning.